Beautiful day out here in Michigan, at least. Hope everyone's getting outside. Yeah, I have like some flickering going on my screen here. But all right, it is what it is. All right, so listen, let's dive in and get started. If you have any questions at all or anything that you wanted to post or bring up, please have that ready and feel free to add it to the comments. You know, I have a few things I wanted to touch on here, but what I really get out of this is hearing what's on your mind and having a discussion around that. So with that, let's get started. A couple points to bring up. You know, the longer, every day you're going to start getting information that now I guess it depends who you trust, right? But there is more and more information that just is not, it just doesn't, it either doesn't tell the whole story, it highlights certain parts of the story to make a point, or is just outright damn inaccuracy. and that's certainly around as well. So I want to give kind of what I've taken in this last week and give you a summary of where we're at, where we're going, what to expect, and hopefully it could give you a better frame of mind and help out. So, most of the people that I'm reading and talk to and studies that I'm reviewing, we probably have an infectivity rate in the United States on average around 5%. Maybe it's a little more, maybe it's around 7%. So that means that out of whatever million people, 340 million people in the country or so, I don't know the exact number, about 5, maybe 7% or so has been infected with COVID-19. There are some studies and some papers that are coming out with much, much higher infectivity rates, and that's probably not the case. Maybe in some hot spots it could be a little higher, but let's just take 5 or 7% overall. The point is, even if it was 10%, it doesn't matter with this point, in that the impact, the duration of living with COVID is going to be months to, a year to even 2 years. Okay. It's important that people recognize that this really ends. Okay. And there's really no end anymore, but we could move into a state of a different environment in one of three ways, or all three happening. Number one, we reach an infectivity rate of 60, 70, 80%, somewhere around there. And at that infection rate, at that prevalence, we probably get herd immunity, which means that the spread of the infection is going to be a lot less. Okay. And that's what vaccines do for us, right? If you could get a certain number of your population, certain percent of the population vaccinated, it will eventually lead to herd immunity. So you don't need 100%. You want 100%, because then you could actually eradicate a pathogen. But if you get to 80%, let's say, then most people are going to be protected. That's number one. We reach herd immunity. Number two, there's a vaccine that's effective that is produced, and that is still way off. Probably not 6 months away, probably not 12 months away, probably more than that. Or number three, which is completely unpredictable, but there would be a mutation in the virus that changes the virulence, that changes the severity or the infectivity of it. So barring numbers 2 and 3, we're headed probably towards a herd immunity. Or if we get some nice breakthroughs, we'll be headed towards number 2. So what does that mean? That means that while there's a big push to leave our homes, to get out of shelter in place, and to return to the community, our expectations need to be that inevitably, when we leave our homes, the infection rates are going to climb again. It's inevitable, okay? How high and how steep that climb is going to depend on what behaviors we take on when we are back out there. So think about it this way, right? We knew, pardon me. So we knew that the more strict, the more stringent we were in sheltering in place and physically distancing, that the curve would eventually flatten. And we knew the sooner and more aggressive we did that, the faster that curve would flatten, right? Everyone agrees on that. And what you're seeing right now, the plateauing of cases, and it's plateauing, it's not declining. It's definitely still up there. But that is a direct result of our behaviors. So for anyone out there who says things like, oh, this isn't even close to what it was predicted as far as infections or infectivity, trust me. First of all, in the United States, we're at 1 million people, and our number of deaths, I don't even know, it's over 50,000, and each one of those is someone, right? It's someone's husband, wife, parent, someone. But we're 2 months in with strict sheltering in place, right? Unbelievable response that we've had around the world and in the United States. And by the way, the United States is far the number 1 hotbed of COVID-19 in the world. We have 25% of the world's deaths, unfortunately, and we're 4% of the world's population. So while what we've done has been extraordinary, there's lots of improvement. But let's get back to the concept of what we just did was flatten out this curve. And we know the behaviors that did that. That same idea, now we have to inverse, right? We have to flip it, in that when we go back out, we have to maintain a new set of behaviors, in a sense, so that we don't raise the infectivity rate again. So now it's not necessarily about flattening the curve so that we don't overwhelm a healthcare system. That's part of it, but kind of the sub part of this is that we are going to be living with now a baseline level of infectivity, right? So there will be risks when we reemerge, when we emerge and go out into the public. There will be risks. What we need to now do is communities need to track. I mean, ideally, this comes from the federal government, right? And I was talking to my wife the other day, and I said, it's amazing if a foreign power invaded Massachusetts, right? The federal government wouldn't say, or invaded, some states in our country, or invaded our country. The federal government wouldn't say, all right, Massachusetts, New Hampshire, and Connecticut, you guys go, and out there in Colorado, you don't have to do anything, right? This is a national response. And so ideally, it's a top-down leadership approach. We need the proper testing in place. We need the proper contact surveillance in place. And we need the proper support for our healthcare system. All right. That's a whole separate issue we could get into. But what we are going to face is, as we emerge from our homes and go back out into the world, we have an infection rate. that infection rate, depending on our behaviors, is either going to slightly increase and it's going to be a slow burn for a long time, meaning it's going to just continue until 70 or 80% get infected, or we get a vaccine, or we're going to see a steepening of the curve again, and we're going to have increasing infections until your mayors or your governors are going to enact another shelter in place. This is inevitable, okay? We are either going to have a continuous slow burn, which is less likely. The more likely scenario is we are going to have a rise of infections, maybe in a month, right? Maybe in a few weeks, maybe in a month, maybe in 2 months, maybe in 6 months, right? There's no way to predict when that's going to happen. It could be in 9 months. The greatest certainty is that it will happen. Okay, the virus does not care. Is not keeping track of whether it's May 15th or is not keeping track of if you have summer camp or anything like that. It's going to rear its ugly head whenever it wants. Right? It's searching for humans to infect, and certainly there may be a seasonality. Right? Like that's not uncommon. But don't let this idea of a seasonality all make you believe that this will not reappear. COVID may be minimized in the coming months. It's possible, absolutely, but it will not disappear. And at some point, it would continue to rise. It will cause infection rates to rise again. If anyone tells you that they know, we're going to see a drop of infections simply because it's summer, that's not true. If anyone tells you they could predict the course of this, that's not true. Okay. The main predictor is going to be what we do, what humans do when we're out in public. If we're out gathering in groups and we're not abiding by physical distancing, infection rates will climb faster. If we go out in groups and most of us are abiding by physical distancing, proper hygiene, infection rates will climb at a flatter curve or more of a slow burn. Okay? We decide as a population how this is going to play out. And the virus also has a say in that, for whatever reasons, viruses sometimes spark up in infections and sometimes they slow down. There's some parts to that we just don't know. So that is one of the big takeaways here, in that we have a long way to go. And the next big task, the next big feat of humans is to manage the next phase of going out there and still having risk, and still knowing that infections will occur, and still knowing that we may be back in our homes in a matter of a month or 2 months. That's a very real probability. And understanding that, getting in the mindset that push and pull, right? That back and forth, that whiplash, that's going to take a very big toll on society. And that is going to have an immense emotional, psychological impact on us, right? One day your kid may be in school, or one day you may be able to go to work, and another day you're told to stay home again. And it's totally unpredictable right now. Ideally, we have surveillance and we have testing that is measuring like a speedometer, right? If you had a speedometer or a thermometer, right, and you knew if that thermometer goes, from 70 degrees to 78 degrees, we better slow things down and pull people inside, because otherwise we're going to reach this point, this kind of escape velocity, where we're going to start overwhelming a hospital again. that needs to be avoided. So is it possible to get a worse situation than we were just in? Absolutely, right? There's no question that we could be in a worse situation. Could we be in situations that are half what we just experienced? Absolutely. That's a possibility as well. The closest certainty we have is that this will continue for months and months, probably a year, maybe 2 years, maybe even more. It all depends on the percent of the population infected or whether we have an effective vaccine or not. And so the conversation that we need to be hearing right now is, how do we build the infrastructure for getting back out? And you'll hear so much about testing and contact tracing. And I don't know about you, but there's nowhere in my community that I could easily get to do serologic testing or diagnostic testing. I mean, it's coming. It's entering, these areas. I know in Detroit they're starting it, and there's some areas in Oakland County, but it's not easy yet, and it's not universal yet. And if you're in Bozeman, Montana, you may not have access for a while. Eventually, we will have access, right? It's 1 month from now, right? The end of May is going to look very different from where we are right now, and the end of June is going to look very different. We will likely have much more expanded testing, but right now, testing is limited for various reasons. Number one, there are tons of tests out there on the market, some FDA approved, some not FDA approved. Most of them are less than perfect, and that's a big problem. So it's like the Wild West right now in testing, and that will change. That will be reined in, but we really need the FDA and the federal government to step in and to provide some better regulation with testing, so we could get some good, accurate testing. Because the worst case is that you're told that you are protected, that you have immunity, and you actually don't, that it's a false positive. And right now, some of these tests have 20% false positive rates. Even 5% or 10% is high. 10% is very high. And some of these tests are experiencing that high of a rate. Okay, so if I were to boil this down really at this stage to 3 things, number one, maybe 4 things. Number one, we are going to see probably multiple peaks. We're dealing with a highly infectious virus. It's only infected a small part of the population thus far. Extrapolate out the math, and you can see what we're headed for. Number 2, we need leadership everywhere. So, ideally, you start at the highest level of federal government and you work your way down. Leadership is the central, it's the bedrock of good management in epidemics and pandemics. We need fireside chat capability, right? We need leaders to connect with people, to provide information, to be trustworthy, and to be honest. Number 3, we need expanded testing. We need a national initiative for testing so that this is run by the federal government, that all states are on board, that we could flex our muscle in certain states over others who may have hotspots or greater populations in order to identify where infections may be rising, and alongside of that, contact tracing. Number 4, we need hospitals to be able to handle a potential future surge. We don't want to be caught with our pants down like we were in March, and we need to make sure that hospitals are prepared. Now is the time to prepare. As cases are leveling off and declining, hospitals should be stocking up on PPEs. They should be providing mental health services. They should be building in redundancies, contingencies, and getting ready for this next wave. Okay? Whether or not you get a big wave doesn't matter. We need to be prepared for it so that we have the best possible response. And for people who want to highlight countries such as Sweden or Singapore that said, oh, they're doing it so well. Singapore has been on a national emergency again, simply because they left their homes, they opened up, and they did not take the proper, or I shouldn't say that. I can't tell you why, but their infections surged again. And so they were on national emergency and shelter in place. Sweden as well is seeing an uptick of infections, while other Scandinavian countries who put a shelter in place and have been working with a better infrastructure of testing and masks have been doing much better. Okay. Woo. So let's pause for a minute, see if we have any questions here. Oh, we got some. Okay. Let me try and pour through this. Oh, Christine, just by the Hudson in New York, people are everywhere. Well, here's the deal, when do you see, when's the situation going to change? And you could just say, just wait a few weeks, a month, 2 months, and always remember, right? You're at minimum 2 weeks behind. And when I look closely at the national infection rate in the United States, we saw a peak. It started coming down a little, and I'm seeing kind of a leveling off right now, and even a little curve up, which is making me a little concerned. Another question is, can a housekeeper come if he or she wears a mask? This is going to be a personal decision. So my worry is a couple things. One, a housekeeper, you would need to make sure that whoever is entering your home is properly wearing a mask and has a proper mask. Speaking of masks, I will tell you, give me 2 seconds. I'm going to run. I'm going to get a mask here real quick. Hold on. Okay, so here's the deal with masks, and I figured I'd do this. So remember last week I told you I ordered a box of masks from stadiummasks.com. It's as it sounds, stadiummasks.com. I spoke to them, got a 5% discount, save 5. And these are the masks I got. I got a few boxes of these. And I want to just go over this because I think it's important. These are KN95 masks. So hospital employees in the United States are wearing N95 masks. These are KN95 masks. Just means that they're made in China, but that they have a protection level equivalent to N95 masks. And this is what's so important here. You may have someone who comes into your home who's wearing a mask, but they're not wearing the mask properly. And it negates the whole purpose of wearing a mask. So let's go over the proper way of wearing a mask right now. And before I put this on, I want to say a couple things, right? In an emergency room, before we even are allowed to start in our residency training, we get fitted for masks. So just think about that, right? We're not allowed to see patients until we go through a mask fitting. Yet we're asking hundreds of millions of people to just slap on a mask. And they're not trained, fine, no big deal. But at least let's talk about the right way to wear the mask, because if you're not wearing it the right way, you're just exposed like you're not wearing a mask. The mask serves as a barrier. And what that means is there needs to be a seal both around your mouth and your nose. I see front page of the New York Times 2 days ago when Atlanta, Georgia opened up, or Oklahoma it was actually as well. There was a picture of a barber cutting someone's hair, and the mask is below the barber's nose. Totally worthless, okay, for that mask. In fact, COVID-19 is harbored in your nasopharynx. So that person is absolutely not they could be infected, like they weren't wearing a mask. When you have a mask on, you need to do your best to create a seal around your mouth and nose. Okay, so when you inhale, you actually could appreciate the mask indenting, right? You want almost a vacuum-like environment to bring the mask in. And when you exhale, the mask will kind of pop back out. So it will go in and out, right? Like a diaphragm, in and out, in and out. That's the ideal situation, all right? If you see your glasses fogging, you don't have 100% seal. Now, you want to get as close to 100% as possible, all right? So let's do this. I'm going to tell you the one tip you could do. If there was only one thing to get this right 90% of the time, this is it. Every proper mask will have some type of object or some type of bar on the top here. If you see on N95 masks, it will be a metal bar. On this N95 mask, it's like a hard, it's like a twist tie on what you use for bags. So the way you would do this is you put this around and then you pinch the nose. And you want to create a seal. So you could see how the mask comes in and out when I'm breathing. That's a proper seal. I do not feel air coming out through my eyes or down through the mouth. Now, this is not the perfect fitting mask for me. It's a little, I could feel it's not perfect, but I'm comfortable seeing that the mask is going in and out. Now, if I'm out in public wearing this, I'm not going to be yapping like I am right now, right? I'm going to be pretty much not talking and just maybe food shopping or just walking around. So it would look like this. Now you could see the mask going in and out, and I'm totally fine with that. So I feel pretty comfortable with this. So if you, and the other rule, so 90% of correct mask wearing is getting the seal, pinching the nose. Okay, it has to be pinched because that's the way the seal is created. Number 2, once the mask is on, do not touch the mask. You will want to touch this mask, okay? And I'm doing this for demo purposes here. Do not touch the mask. The whole point is that this mask becomes a barrier for infection. And by touching it, you do a couple things. Number 1, you may destroy the integrity of the mask, right? The oils on your fingers, the moisture on your fingers could end up causing a defect in the mask. Number 2, the mask is potentially contaminated. So you don't want to touch your mask. Now, the classic scenario I see is someone going up to the meat aisle in a store or getting some bologna, and they go like this. Yeah, I'll take half a pound of Hebrew National salami. And they're like this. Don't do this, okay? Keep the mask on and don't touch it. All right? Don't touch it. Now, what do you do when you come home? Let's say you go out and you come home and you need to take off your mask. Don't touch your mask. Use your fingers to take off whatever's holding your mask in place. Hold it by the string and then hang it up. Okay? What I would do with this one right now is I would put it, I have a little hook outside. In nice weather, I just hang it out. There's air, there's wind, there's UV light. I'm not talking like the bleach and UV light type stuff here. I'm just talking natural UV light. I just kind of let this air out. Maybe there's moisture from breathing. So if I'm going to reuse this mask, that's what I would do. And then I would bring it inside and put it in a place that's just isolated. Whether or not I use it for the next couple of days, ideally it actually gets after 2-3 days, right? The virons that were on it will end up being eliminated and die naturally. So that's that with the mask. So why did we start talking about this? The purpose was, can we have someone come into our house? And think about this. This will answer many questions. Can you have a house cleaner come in? Yes, Mom, for my mom's question, I'm going to call you about this one because I'm more concerned, in an older population here. It's just so critical that the people who you come in contact with, that you rely on them wearing the mask properly, that they're doing that. Okay. So I would have a discussion. You could take what we just spoke about, and if someone's going to enter your home, before they enter your home, you have the discussion. Before you come in, you need to put on your mask. Your mask needs to have a seal. I need to see that you're able to, that mask itself is able to indent and extend. It's able to in and out like a diaphragm as they breathe. Now, for example, I bought 4 boxes of these. There are 30 masks a box. And my intention is to be able to provide this. If someone wants to come in my home or whatever it may be, and they don't have a mask, well, they're not coming in my house unless I'm going to give them this mask to put on. Okay. Ultimately, I think I ended up paying, it's like, I don't know, $3 a mask, but hey, that's the investment that I want to take so that potentially I could interact with people, but still maintain physical distancing. Just because I'm wearing a mask doesn't mean I shouldn't maintain physical distancing. It just means that I have another barrier, and the likelihood of being infected is much, much, much lower, close to zero. In fact, if you're wearing a mask properly and you're physical distancing, the likelihood of you becoming infected is close to zero. It's not zero, it's close to zero. Think about that, okay? Think about that, because that is how you get back into society, and that is how you safely get back into society. All right, next question. Have we seen any hopeful statistics from other countries affected by this that reopened? It's just too early, right? The whole beginning of my of what I was talking about was, yes, reopening. We know infections are on the downward, are going down or plateauing, but they will pop back up again. It takes time, right? And the steepness of that curve will be variable in other places. All right. So hopefully the whole beginning of this talk touched on this. And, there's a saying that, just wait, you want to know what's going on in another country, just wait 2 weeks and you'll see. So this is a good question. I want to get this out there. Differing information, but is there some more data, Dana Green-Witter, regarding getting the virus again once someone has it? So there's some really bad information out there about this. And let me tell you, now I'm not talking with 100% certainty here. All right. Right. I can't be 100% certain, but pretty darn close to certain, is that once you get infected and you've mounted a strong immune response, and that strong immune response is the level of antibody in your blood that would protect you from the virus at a second exposure, there's a certain level that you will be deemed immune. What that level is not necessarily known, but we will know that level, right? But you need research to establish that level. We could use historical levels, of course, right? So if you know someone's baseline level of antibody and then you see an increase in that response, then you could determine whether someone is protected or not. A 4 times increase in antibody level due to presenting that infection, that pathogen to them, confers immunity, let's say. So that information is going to be out, but it's very, very unlikely that if you were infected once and you had a normal immune response, like you're not on an immunosuppressant, that you have had a normal immune response, that you will be protected. We don't know how long you'd be protected for, but in the short term, you should be protected. Okay. All right. Cousin Merrill, how's it going there? All right. Do you expect another shutdown in the fall, winter? Also, is it realistic to expect an effective vaccine in a year or so? So, as far as the shutdown goes, it's completely unpredictable. But what I would expect, what I think you should prepare for, is another shutdown. Whether it's the summer, the fall, the spring, there's no way to know. All right. And we'll be able to look back at this because I promise you that there is a good chance we will have a shutdown again. When that will be is unknown. If it's not a complete shutdown, we will have localized shutdowns, or they may come up with some other term. Maybe it's called a slowdown or something like that, right? Where just people, maybe we just cancel events or something like that. But there will be something, okay? And the vaccine, again, vaccines don't get made in 6 months. It's something more like a year usually, maybe more. And it has to work, right? I mean, anyone can make a vaccine. We can make a vaccine, but we need to make an effective vaccine. Okay. Allison Johansson, you speak and explain so well. Well, thank you. Thank you for that feedback. Sometimes I just think I'm speaking into a screen and only seeing myself here, so I get no feedback. So thank you. Kevin James, how are studies looking as far as people that have been infected getting infected again? Just answered that. I'm going to put a little, how often do you can see, you can finish that. Daniel McGuire, if you haven't read At the Dark End of the Street, it's a phenomenal book. At the end of this, can you do the Angry Jersey Man version of what we need to do? I like it. Okay, redo. Felicia, how often do you think we need serological testing to see if someone has immunity? I don't have an answer to that. I don't know enough about that other than serological immunity and diagnostic testing is going to be so critical in getting some semblance of normality back, okay? Because if we know who has immunity right away, those people could go out and start re-engaging at a very high level in society. They could re-engage with family and friends, and those people are going to be like the gold to our society, okay? Those are really important. How often? I don't know, maybe every month, something like that. That seems reasonable. I'm not sure. But imagine this. Imagine 360 million people or 300 million people getting tested every month. We won't have the capacity to do that. So even though we want to test, right now there is a Wild West in testing. And we won't have the supplies, right? America doesn't have the supplies. The whole world wants to test. 7 billion people are trying to get tested. And this is where the problem is, right? This is not just a localized, like Cincinnati needs tests. The world needs tests. So think about these implications. No one is commenting on things like this. All right. There's very few people. There are people because it's people that, I'll talk to or read about or engage in what they're writing about. But that needs to be the conversation. Okay. Another vote for the angry Jersey guy. When was I angry? I don't remember being angry. I don't remember this. Okay. Sarah Behoff, I don't care if I'm told everyone is open. I do not trust COVIDiots around me in Wisconsin. Wisconsin will definitely be seeing a spike within a month. Okay. Cuomo stock, he's 70%. Yep, absolutely. So they're preparing. Derek Cass, by the way, guys, if you have not already been following Daracas. Let me just give a shout out. First of all, there's an interview with her on Conversations. I got to plug that first. All right. Go to Conversations with Adam Rosh on Apple Podcasts and listen to it. It's great. About Dara's an emergency room physician, frontline, really doing amazing work with getting the right message out with COVID. She's a great resource. You could see her on CNN, NBC, and lots of different outlets. You can follow her at Twitter, Facebook. I really urge you guys to check her out because the information is very valuable. And she is she's a wrecking ball when it comes to getting things done in a good way. Okay, meaning when there's a challenge, she goes head first. So thanks for joining this, and let's see your question. He actually said, okay. So you have your comment here. Megan Pape, Julian. You got to tell me how to pronounce your last name. Juline. Okay. Given that we don't have a true understanding of what the denominator actually is, what is your best estimate of what the mortality rate is? Even if it's 1%, right? Even if it's 0.5%, that's huge. Okay. The standard flu, influenza, 0.1%. Now remember, when you go to 0.1% to 0.2%, right? That's a doubling. That's 100% increase. When you go to 0.1% to 1%, right? That's an enormous increase. What is it? 1,000% increase. Check me on that. I could be wrong, but I'm pretty sure it's accurate. So let's just figure 1%. And you do the math. If we have 70% of this country infected, take 1% of that. But numbers don't do justice because right now we're at over 50,000. And every one of those deaths is a real person, right? Sometimes we're focused on the denominator, but it's the numerators that really matter here. The numerators are what matter. So excellent question. And eventually we're going to get more and more of that data. Next question. I'm hearing a lot about putting people on respirators. Is a generic response that is doing more harm than good. Why is this continuing to happen? So this is another great question. And, some of this is, kind of medicalese here in that, there are some good articles. There's some debate going on, but Richard Levitan had a nice article in the New York Times the other day. And not to get too technical here, but, and I touched on this last week, really, let me sum this up as general as possible right now. It's not that excuse me, when someone has an oxygen level of 70%, right now you're probably all at 95% or higher. Right? You walk around at 98, 99, 100%. That's the saturation of the hemoglobin in your blood. Anytime someone's at 60, 70%, they're extremely ill. And in hospitals, right, those patients get a breathing tube. That's been the standard of care for a long, long time. What has been, some things that have been talked about is that maybe those patients don't need the ventilators right away. And that those ventilators may be causing potentially more harm, right? Because it's not the ventilator itself. It's the fact that, right, to maintain these people, you have to have pressure regulation. You have to have there's a lot of vent management complexities I'm not going to get into here. So there's been a lot of some hospitals, some physicians have been seeing that maybe by holding off as long as possible before the ventilator is going to be used, that maybe it's actually improving mortality. These things are being studied, and we're going to find these things out. The takeaway is this, that if you need a ventilator or you're considered to need a ventilator, you are sick. And so any intervention on those people is really hard to study because you're so sick. So those people may die with or without a ventilator. And that's research, how research goes, right? When you study sick patients, your outcomes, you have to be very particular in what your control is, right? What are you comparing it against? And so I'll leave it at that. I could say this, no emergency room doctor or any doctor out there is intentionally putting a patient on a vent for harm, right? It's trying to understand the progression of illness better, and we're learning more every day. What we know in 1 month from now is going to be very different from what we know today. And as long as we focus on studying the response, that's what we need. Not to throw out things like drink bleach or put UV light in. And look, I hopefully no one on here takes that seriously, but you have to take it seriously enough, because there was an increase in calls to the New York Poison Control Center of people drinking bleach. Okay. So, let's stick to rational science, and it's great to be innovative. It's great to challenge the status quo. Absolutely. And it's great to think out of the box, right? But it's also important to stick with, some common sense as well. All right. Samantha Millman Conchiger, how you doing? How would you know it is safe to send your child to sleepaway camp? Some are saying they will not open on time. Yeah, the camp issue is a big deal. There's a lot, this is going to be a personal decision. And I think camps could do things to provide some infrastructure. I think, so this is a personal opinion here. I feel like camps should open as long as they take proper precautions. But ideally, there is available testing. There's available diagnostic and serologic testing. Ideally, there is support and infrastructure. There's redundancy and contingencies in place for all of these things. The hardest part I see of camp is managing the adults that are there and managing the return of campers. But any problem we have in camp is going to be echoed in dealing with school, returning to school in September. I think we can do it. I think if we have the proper leadership, we should absolutely be able to do it. And that's the most I could say on this. I could tell you personally, if camp is open for my kids as of today, April 28th, I will send them. But I will do it for the 2 camps that they go to, because I've been in touch with the camp directors, so I know their thought process, what's important to them, and the approach and safety that they're taking. And when my camper if the kids, if they do go to camp and they come back, one of the benefits or privileges that I have, the things that I have the ability to do is, for example, my wife would end up staying with them for 2 weeks, and I'd go live somewhere else for 2 weeks if we do not have testing available to us, so that they could be self-quarantined for 2 weeks away from me. Only you looking at statistics saying that a 40-year-old healthy woman should fare better than a 44-year-old somewhat healthy male. All right. So Lisa Spannerman, I ordered these masks after I saw your last live stream. Thanks so much. You bet. And you could get I got 5% off. If I put in say 5, I got like $20 off. In case it's $20. All right. Yes. Okay. Yeah, Dr. Rose Monton, absolutely. By the way, if you don't follow Dr. Rose Monton, I highly suggest you find her on Facebook and Instagram. Take a look at. She's here in the comments. I love the work you do. Very inspiring and very grounding as well. So thank you. And yes, PSAs on proper way to wear masks would be wonderful. Brian Gargano. So no, here's the deal with these blood clots and things like that. So this is not this is not a new phenomena. So the virus is causing coagulopathy, and anytime you have this, you hear about cytokine storms. Anytime you have an upregulation of your immune system and messaging system in your body, oftentimes it leads to something called a coagulopathy. So all of your blood clotting factors go haywire. And, we see this in infections. This is not, new. You could get things, there's something called disseminated intravascular coagulopathy. And, right, you could get bleeding in addition to clotting. You could actually get both at the same time. So there is a lot of evidence that COVID-19 is causing a coagulopathy type state, or someone becomes prone to thrombosis, prone to clotting, and they may get blood clots in their lungs, blood clots in their brains that people are calling strokes. So that's part of the pathophysiology of this. But again, it's the same idea. Like in a month, we'll know a whole lot more than what we know right now. All right, now we're getting Darth Vader masks in here. Nice. Hebrew National Salami, my favorite. I just bought one of those tubes of Hebrew National Salami. It was great. Should you be wearing masks in the car? I do not wear a mask in the car. It's a fine question to ask. I do not see any benefit of wearing a mask in a car because, unless you're with someone in the car, then I'd wear a mask in the car, maybe if they're in the back seat. But you should be physically distanced from them, ideally, right? Now, if it's a family member or kid who you've been living with, no big, you're gonna stay together there. But no, otherwise, no. Christy Connie, what about masks for kids? The only ones I've seen that are their size are homemade made of cotton. Yeah, it's a great question. I think kids are just right. They're gonna be exposed. They're probably not gonna wear masks the right way, and it's probably not worth putting them on. It's probably not worth putting on masks for kids. I think it's the adults that need to wear the masks, and that's probably going to be your best bet there. So I don't see myself putting masks on kids. Potentially, one scenario would be is, let's say we were taking a flight. And I was going to be with the kids for a while. I put a mask on them, let's say, and then so that I can remain with them. But all of these tenets, principles go out the door once school starts. Right? Everything I'm talking about now is erased once you have school, because there's going to be no way to protect them with the interaction of coming home from school if you send them to school. Those theories are done. Unless we have testing. Testing will change the score here. All right. Everyone is taking their shoes off and leaving them outside. If you're just walking around the community, shoes aren't. You don't have to worry about shoes. If you're working in the ER or a hospital, or if you're around infected people, then I'd take off shoes and leave them outside. But not if you're just walking around a community. Roberta Green, best idea yet. Marsha, make Carl clean. Alvin, can you use surgical mask in a ward with COVID-19 patients, or you need N95 masks? Well, my advice there is N95 masks. If you're in a hospital with COVID patients, N95 masks are the way to go. That would be my take on it. Kelly Maureen, this is so helpful and your explanations make so much sense. Thank you for educating us. You're very welcome. Great interview with Dara. Thank you. Andrew Reese, by the way, if you liked the interview with Dara on Conversations with Adam Rosh on Apple iTunes, here's another plug. Yesterday, we launched one with Angie Povolitis, the Assistant Attorney General who prosecuted Larry Nassar. And next week, I believe, we're going to be posting the one with Andrew Reese. It's incredible, not to be missed. So the question is it possible to buy sport masks made from quick-dry material that will take a filter material equivalent to N95? It is also possible to put the N95 inside, which may help its integrity. I don't have a good answer to this. I don't know enough about, the engineering of these masks. It sounds like what you're talking about there has some promise, and I think you could probably find out this information. There are probably engineers out there who can answer this for you, and I could certainly help you do that and find someone who will know that information. Next question. Working in a high-risk setting and seeing people who are positive now. So spreading the infection. So the CDC has guidelines, right? You could do a testing route or a non-testing route, but if you tested negative, they want two negative tests within 24 hours and a decline in symptoms. So I would say that. Excellent. So thank you, Andrew. He's going to post something. Daniel McGuire, can you touch on the 2 doctors online who are suggesting COVID is not as bad as the flu? Yeah. So there's videos of 2 doctors online. I think they're out of California. I don't even know. I did watch their videos this morning, and they are trained, I believe, in emergency medicine. I'm sure you'll see this on your feed. And interestingly, while Dara Cass was just on, I don't think she's on anymore, but Dara led a movement that, the information that these people were spewing was not factually based, and it was irresponsible and dangerous. And the 2 major emergency medicine organizations came out with a statement saying that distancing themselves from these 2 emergency physicians. And, while I believe it's important to question the status quo, I believe you have to do it with integrity, and you have to do it through a scientific method. And these 2 did not do that. And they also have a lot of conflict of interest. So, again, and also Dawn Miller sent me something today about a pretty comprehensive fact myth about COVID. And again, it's the same nonsense. And whether there's propaganda around this or what the intention is, I'm unclear. It's unclear. We could suspect motives, right? It is non-negotiable in what's happening and the impact here and what we have in front of us. And for anyone who's trying to spin the data, it's entirely misguided, misinformed, and irresponsible. And you should question their credentials as far as what they represent. So I am out here telling you that there is a lot we don't know, but anyone out there who's telling you, that things are bogus and things, you have to just be super cautious about that. I certainly may be wrong in my interpretation of the data and of the events. But, then if I'm wrong, what I'd like, and I hope I'm wrong on a lot of this, I need to be proven wrong. I need to be shown that the alternative or the other way to look at it is backed not in speculation or not in anecdotes, but in actual evidence that could disprove a theory. Science, the purpose of science is to disprove things. That's what science does. Science doesn't prove anything in a sense, right? Science is about a bunch of people who are trying to take what's perceived truth and tear it apart, okay? That's what the best scientists want to do. They put a theory out there and they do everything they can to disprove it. Because if you just disprove it once, right? It's the idea of the black swan. If you say all swans are white, you just need one black swan to disprove that theory. And that's a main tenet of science. Okay. So, from a medical standpoint and in your personal opinion, do you recommend that all businesses that reopen have a COVID-19 policy which requires PPE in the workplace? That's what would be my preference. I would certainly feel comfortable that I would walk into a store. That store has a seal that tells me that my employees have been PPE trained, right? Just like when I walk into a restaurant, I know that it's been inspected from the health authority, that they have the proper cleaning procedures in place. This is no different. You should have the proper COVID-19 procedures in place. Why don't you write something up on that? I actually like that idea. There should be a seal or a certificate that I'm COVID compliant. CC, COVID compliance. Okay. Excellent. I love Christine's input. Yes. Okay, Sabrina, what do you recommend as the best immune system boosters? Do you know much about colloidal silver? I do not know anything about colloidal silver. What I can tell you is the best immune system boosters for day to day is to go out and exercise, to eat well, and to have a healthy mindset, to meditate, and to be and to reflect. That is the best immune response. I could tell you that stressors reduce immune response, and we have a lot of stressors in society right now. So exercising is the simplest, easiest, quickest, most effective way to boost your immune response. Hands down. You could spend an hour researching supplements, or you could spend 30 minutes doing exercise. And I promise you that doing the exercise will give you a 10x return than any vitamin C pill that you could take. A good diet is certainly helpful, right? Eating healthy, eating good foods, is certainly useful there. Megan McKnight, protocol at Dan's Hospital is surgical masks. That's really interesting. So it's one thing walking around the hospital. Surgical masks are fine, but I think if you're caring for patients who are COVID positive or suspected COVID, I think an N95 mask should be the requirement there. I can't imagine surgical masks being the requirement. So hopefully, at least if I were working in a hospital, that's what would be my expectation if I were caring for a COVID positive patient. But thank you for that. Oh, yeah. So I think there's some more to that. So Shannon Nolan, when do you anticipate the full impact of this will hit our healthcare workers' emotion and mental health? Seeing fatigue and moral injury already, but they are still in the trenches for most of the part. You're seeing that already, right? I mean, we just heard the unfortunate news of the medical director in the emergency department in New York, in Columbia, at the Allen Pavilion, committed suicide, right? Unbelievable. I mean, just tragic, right? Healthy woman, had COVID herself, recovered from COVID, and unfortunately committed suicide. There's no doubt that the greatest impact on this is yet to be seen. The fact that this is long-term is going to be like a prolonged war, right? There's a difference between a 1-month war and a 10-year war. And not that this is going to be 10 years, but it is, the same amount of PTSD and depression and anxiety that is going to be caused from this will be unparalleled from anything we have ever seen in this world. This will be a global epidemic, mental health epidemic for sure. And not healthcare workers will certainly take the brunt of it, but I bet you survivors are impacted as well. There will be survivor's guilt, and just people who are day to day, and especially the older population. They're at immense vulnerability here. and also children. I mean, everyone. I think I just named everyone. The mental health here, we are going to need 10 times the number of mental health workers in the next decade. So if you're thinking about going into that specialty, I am pretty certain that there is going to be a great need. Not only is there a great need now, there's going to be a greater need in the future. Okay. All right. Gosh, we are, wow, that hour flew by. Awesome. I'm glad you guys stayed this whole time. Any other questions? Hopefully I hit on we hit on some really good topics here, and let me know if you want to do this next week or not. I just never know. I never know if you guys want to do this. Give me some feedback on whether or not you want to do this. I think next week it's going to May. Let's see here, May 5th. I think if we do it, we have 2 reasons to do it. Cinco de Mayo, of course, and maybe we come with a cocktail next week. That could work. And then we could celebrate my sister's birthday as well. So I say we hold a Cinco de Mayo COVID-19 update. Drinks are welcomed. Oh, but I can't see anyone. Maybe I'll try to stream this on Zoom or something like that. But at least we'll do it here, and we could do a I will celebrate, or at least acknowledge Cinco de Mayo birthdays out there. So we'll do that. Wear sombreros. You could take pictures of yourself and post them. I think you could post pictures on your comments maybe, and we'll do that. But please just send me a little message or something that you want to do this next week. I mean, it certainly fills my time, and I love doing it. Everyone's talking Zoom. We could do a Zoom. I have a Zoom account up to 100 people. Sometimes those could get noisy though, but we'll figure it out. I'll figure it out for next week. Maybe we'll experiment with it. All right, guys. If you want to post comments, I will continue to answer them. I haven't been as good as I normally am over the last couple of weeks after these are done, but I typically will go back and post comments. So if you have any, feel free. And looks like there's mute everyone. Yeah, I'll mute everyone. I'll try that. Absolutely. What benchmark do we need to hit before we can start letting our kids play with their cousins? That's going to be a testing. That's all about testing, essentially, as far as knowing who's immune and who's not. So, all right. Thank you, guys. Good seeing everyone. I love when you post comments because I don't know who's on the feed. So when you post a comment, I'll tell you what, that's what I ask in return. Just post a comment, say hi, so that I could see that that you're out there, right? The distance, you eliminate the distance by making yourself present, and that distance is really valuable. That's what brings comfort. That's what brings calmness to things. So, Mikey Russo, good seeing you. I'll see you next week. Gail Vogel, good seeing you. Celeste, great seeing you. Faith Fisher, hey, I remember Faith. Megan, thanks for sticking around the whole time. Pat Goodspeed, good seeing you. Thank you again. Really great seeing everyone here. Gargano, good seeing you. And all right, we will call it a day. Have a wonderful one. Ciao.